Before we begin, I'd like very much to thank Professor Connect and Marcus Hambeck and the rest of the organizing committee for the opportunity to be here and to chair this interesting panel. You've met Professor Gleason. He's professor and chairman at the Institute of Neurology in London at Guy's Hospital. Professor Boots is the chairman at University of Bonn. You met him before and heard his nice lecture. Professor Wolf Mann is a professor and chairman at Medical University in Mainz, and of course, Professor Shah is the head of the Head and Neck Service at the Memorial Sloan Kettering and professor of surgery at Cornell. So we have a very distinguished panel. And I've elected to have this panel to complement the lecture of Professor Gleason. Okay, well, this field has its ups and downs, just like the funicular that goes up and down the mountain in Pittsburgh. And it's really not been clearly established what treatment modalities provide the best outcome. As Professor Gleason pointed out, most of these are discovered late. There's not very much of first level or second level evidence about what to do. And this, with a lack of a universal staging system and variability in surgical nomenclature, limits making use of published data and meaningful analysis. So we have to be guided by our own wisdom and what has gone on before. And speaking of what's going on before, this is from Dr. Connolly's book back in 1967. The chapter on cancer of the ear was written by John Lewis, who said 10 years have passed. So that puts it in 1954 since the first radical surgical procedure was performed for cancer of the ear. At that time, they carried out the first combined one-stage intra and extracranial operation to remove a cancer of the ear. And since that time, up to 67, they had done 60 such procedures. And here you can see the illustrations from that wonderful article. That's certainly worth reading for people involved in this area. And we're still pretty much doing the same thing as during that time. And since we don't have any radiation oncologists or chemotherapists on our panel, we can feel free to speak freely about this. And so we present from Dr. Lewis the 5-year cure rate of extensive cancer of the ear, which was operated on following failed radiation, was 23%. So the first case I wanted to present actually turns out to be my next door neighbor. And about a year ago, he called me from his home in Florida, and he told me that he had an ulcerated lesion in his left ear, which he discovered 2 weeks ago, and had been biopsied by a local ENT doctor, and he told him that he had squamous cell carcinoma, well differentiated, and had him scheduled for surgery. So I suggested to him in no uncertain terms that he return to Pittsburgh for a more comprehensive plan of evaluation and management. And this is my neighbor's ear. Professor Shah, how would you approach this? It's already been biopsied. We know squamous cell carcinoma.
Well, we clearly need the medial extent of the tumor and whether there is any bone invasion. So either a CT scan, which I think we need, but a CT and MR, both would be desirable. I usually do both because both of them give you different pieces of information. And CT is great for minor degrees of bone invasion. Requesting CT for ear canal cancer, we need to be specified to the radiologist. Don't send for skull-base X-ray, it's useless. Specify you want temporal bone films, and then you will get what you need. So I would order a very thin slice CTs, both in axial and coronal planes, and also an MR for the extent of soft tissue disease around the ear canal into the TM joint where CT is not that great.
This patient also underwent PET CT scanning. As you noticed in the CT scan, this tumor only goes up as far as the bony meatus and does not invade into the bony meatus itself. So here's the PET CT, and you can see enhancing mass in the lateral canal. And here also are lymph nodes that are visible on the scan. So this is in the parotid gland in the upper part of the neck. So we've, I think, answered, Dr. Shah answered the question about further evaluation radiographically. Professor Mon, anything else to be evaluated in this case prior to making a plan of management?
Well, I personally, but this is my personal preference, I would do an ultrasonography of the parotid gland, and I would do ultrasound of the head and neck and look if there is any further lymph node involvement further down. But this would be, for the primary evaluation, sufficient for me.
Mm-hmm. This brings about an interesting point. If this patient had a complete CT of the neck, this one already shows the lymph nodes, but let's say for the sake of discussion, there were no radiologically demonstrable lymph nodes, we would do sentinel node biopsy on this patient. This is a large-sized squamous carcinoma with a high potential of occult metastasis. And therefore, we would do a sentinel node mapping on all squamous carcinomas, whether it is ear canal or facial skin, bigger than 2 centimeters. We would do a sentinel node mapping biopsy and plan on doing an elective resection.
We would not do this for 2 reasons. Number one, if there is occult metastasis and you cannot see a large lymph node on the CT scan, MRI, or ultrasonography, post-op radiotherapy is going to treat it as good as does your elective neck dissection. One reason. Reason number 2, that the morbidity is lower for the patient, and we are looking more for the quality of life issue, which is reduced when you add an additional neck dissection.
Okay. So how would you stage this lesion? Professor Boots?
Well, as already has been pointed out, the
well, I mean, based on what the information is available.
Well, it's the CT scan,
yeah.
The MRI, it's got some lymph nodes.
Yeah, right.
And the extension of the primary tumor. So obviously it's a T1, T2, N1 stage.
Mr. Gleason, you mentioned the Pittsburgh staging system.
Well, that would be appropriate to external canal tumours. This is a skin tumour, and so it comes under this category of skin, and it would be stage 3, stage 4 disease, largely dependent on whether those nodes are positive. But you'd have to wait for pathological staging. I must admit, I didn't like the CT scan because that external root canal didn't have air in it. And I don't know whether it had wax in it, but I mean, that doesn't look a very nice tumour to me.
And so given the staging that you have and the information that you have, what type of therapy would you outline for this patient?
Well, I would be resecting the tumour in much the same way that I showed on the slide. If the squamous cell carcinoma was extending down the ear canal, it would take a lot to stop me not doing a lateral petrosectomy. Would certainly do superficial parotidectomy, and I'd take out at least level 2, level 3 nodes. The PET scan would have given you some idea, I think, of whether you had disease further down in the neck. And then, depending on what the pathologist told me, I'd be considering adjuvant therapy.
Yes, Professor.
I think the question is also, if the tumor is limited to the soft tissue, not involving the bone, do you also resect some bone or just resect the soft tissue? From my experience, and you pointed it out, this is always personal experience. You have some cases where you just resected soft tissue, and after half a year, the patient developed recurrence. So is it necessary also in smaller tumors to remove bone as well? Or?
Well, you can't just sort of peel a squamous cell carcinoma off the periosteum and not expect to have less than tumour behind. And you get one bite of the cherry with these people. And see, this is the problem. We're talking to head and neck surgeons, and in fact, we're skull-based surgeons with no otological background, and that helps us slightly. And I think it's an example of where multidisciplinary treatment and management is vital, so that you bring in your friendly skull-based surgeon stroke otologist to manage the external auditory canal for you. I think if it's involving the external auditory canal, it does nothing just to take out the cortex of the internal auditory canal. You can take out the drum, close the ear off. If the patient's worried about their hearing, you do a bone-anchored hearing aid sometime later. But that would be my view. If it was really infiltrating the canal and eroding bone, then I would just do a lateral petrosectomy, taking out the middle ear contents, leaving the facial nerve behind, and closing the ear off. Again, preserving the hearing with an option of a bone-anchored hearing aid at some stage in the future, if the patient wanted it.
I think there is something to be said about examining this patient under anesthesia with small debulking of the tumor to see whether the tumor gets to the drum or not. We all would like to get the entire specimen, Michael, monoblock one piece. But here is the question whether you want to sacrifice hearing versus preserve hearing.
Exactly.
And I would have no objection putting the patient to sleep, taking out a portion of the tumor so I can get a good endoscopic examination of the ear canal, and then make a decision whether I want to do a sleeve resection.
With the patient.
Right. or a lateral temporal bone resection. And that would change my whole sphere, whether I'll do a sleeve resection and a skin graft and reconstruction and canalplasty, or a lateral temporal bone resection and put in a flap.
Well, but I think your concept, I think this is absolutely correct. I also would like to see the local situation before I start doing a whole petrosectomy. And doing a petrosectomy and en bloc resection, I think it's a myth, because in any event, when you have to expose the internal carotid canal, internal carotid artery, and the jugular bulb or the sigmoid sinus, there's no way this piecemeal.
Right,
you cannot do this en bloc, period. At least I can't do it. So you end up doing piecemeal at one end of the game, and the other end of the game you're of course doing big chunks of bone, maybe off the dura of the temporal lobe or whatever. So it's always a compromise. So I think your approach makes very much sense, to look first the local extent of the tumor. Of course you do a piecemeal, and then decide what's the amount of surgery, what's the size of surgery you have to perform. Michael, that's my...
Yeah, no, I agree with you. And this is an extrinsic ear tumor, as opposed to an intrinsic one.
It's clear.
And I think the two are very different.
Is there anyone who would not be in favor of surgical procedure here? How about radiation for this patient, or chemotherapy, or chemo and radiation?
And then operate?
Yeah, or instead of operation.
Well, the patient obviously has lymph node metastases, and if histology reveals lymph node metastases, I would perform post-operative therapy. The prognosis of squamous cell carcinoma in this area is rather poor. That's why I ask, also in small tumors, whether you remove quite a bit of bone, because the recurrence rate is
But this patient is...
so I think that this patient needs post-operative therapy.
Well, the patient's 79 years old, and he has had a bypass procedure, coronary bypass procedure, but he's very fit. He plays golf, and he's had a hip transplant, but he's 79, and he's has this heart disease. Do you still think that he's a fit candidate for surgery?
I would go one step further. You know, this man lives in Pittsburgh, and he lives in Florida. So he's very interested in quality of life. He wants to have a nice life. Okay. And in addition, he's your neighbor, so you have a personal attachment. So in my perspective, he would get the entire treatment as long as it does not interfere with his quality of life. And I would even go one step further. I would add to... I would make a histology look if he is EGF receptor positive, and I would add Erbitux, for instance, to the radiotherapy protocol.
Okay. So this patient underwent a selective neck dissection. He underwent a superficial parotidectomy and a wide local resection of this tumor in the concha, and down to halfway down in the bony external auditory meatus. That's how far this tumor actually extended. And then the patient was reconstructed with a skin graft. And then this is the pathology report, and it showed that this was a 2.5 centimeter lesion. Margin resection were free of tumor, perineural invasion present.